that the disease don't respect borders. So how can you be able to track some disease from one country to the other one if you are not able to share those data? So it was an opportunity to look at those three different axes. Next slide. At the Africa Health, you can come back to the previous slide, please. Okay, next slide. Okay. So at the World Bank meeting in Washington, D.C., where Africa CDC, together with Gavi, Global Fund, and many other actors, were really posing and discussing with a focus on how to advance equitable access to quality healthcare for all in a time where the resources are limited. So it was really an opportunity for Africa CDC and, of course, the African Union to emphasize the willingness to build resilient, job-creating, people-centered health system so that we no longer see health as a charity, but really health as an investment for our community. And the outcome that is expected is really to build a stronger health system and economies to deliver a healthier, more self-reliant continent. Next slide. Going to Kigali, where the Africa Health Tech Summit took place, Africa CDC was really bringing different partners, but more critical, the innovators, the donors, and the industry, highlighting the need for that public-private partnership. The idea was really to coordinate the investment in Africa in digital health system. So the discussion was quite broad, but the main focus was Africa CDC digital transformation strategy, how it can support the acceleration of primary healthcare digitalization, tightening on data governance, linking system into intelligence-driven ecosystem in the continent. You can see that whether it's happened in Kigali or in Washington or even in Germany, we are consistent on our willingness to improve our primary healthcare and also to support the use of innovation on ensuring that we can reach the most at risk and the most vulnerable of our population. Next slide. As mentioned in Germany, one of the key pillar, apart from all what you already mentioned of primary healthcare, is really the call for equitable countermeasure access. Really, the push for Africa CDC to engage global partners to champion for equitable access to those medical countermeasures with priority to conflict and fragile settings. We've seen it during COVID, where we were not prioritizing access to vaccine, to diagnostics, to PPE. We are also seeing, even for mpox, where we are really challenged to have the amount of vaccine that we need. So it was the platform for us to reemphasize the need to push for more equity and to strengthen the regional solidarity through Africa CDC pool procurement. The idea is very simple. Africa is 1.5 billion inhabitants. Africa CDC can play a role with the African Union in ensuring that we have this pool procurement. So if one country wants to procure some medical countermeasure, as compared to Africa CDC and the AU, who can procure for 55 country, you imagine that there's a huge difference. So that will support the harmonization of regulation, but also pushing to our agenda toward equitable access to life-saving tools. Next slide. Now we are really excited and happy to host you here from Durban in South Africa, where we have this conference. And this conference is happening in Durban, where we have health leaders, innovators, partners, and scientists, really scientists, gathering to drive the new public health orders forward. It's really the opportunity where we wanted this time to have a conference more scientific than the politic one. So you will see that we were having more than 1,000 African scientists all together yesterday for the opening, and more than 26,000 people who were connected in all the social media who were able to get to hear from our Director General John Kaseya of Africa CDC, Professor Janabi from WHO, the AFRO, the ADI, but also our governing chair, His Excellent Dr. Elijah Muchima, Minister of Health of Zambia. We were also our great partners from the Global Fund for UNICEF. The conference is co-organized with BioVac. So we had the president of Africa Bio, Dr. Nala Somi. And then, of course, we are in South Africa. So we have the pleasure to have the Honorable Minister of Science and Technology and Innovation that were also present. So this was really the place, it is the place where scientific evidence meet action. So all those scientists are discussing, engaging on primary healthcare, on digital transformation, on epidemic preparedness and response, together with the member state. And all those recommendations will now feed the ministerial G20 that will happen in the next 2 weeks. And they will then take all those recommendations to feed the presidential G20. So it was an opportunity that we could not miss. Despite the fact that we had to organize in a very short time, we are significantly and greatly happy to see all those scientists bringing together. We will definitely push and ensure that our voice, our evidence, lead the discussion that will happen for the G20, which is currently led by South Africa. Next slide. Now, coming back to our public health event, we still have those 5 key diseases, the mpox, cholera, measles, dengue, and Lassa fever. And as we go, we continue to see that the number of moderate risk are increasing and will definitely be more than what we've seen in 2024, where we were having 147. To now, we already have 124, and we still have more 2 to 3 months toward the end of the year. Same for the Iris event, where we have 55, while the entire last year we have 72. So we have that increase, which is definitely the product of the different driver. We mentioned many times the global warming, but also the different crises, as we will see later with the issue of cholera that is affecting different countries. Next slide. So the good news starts really on the side of Ebola virus disease in DRC. So you remember that months ago, more than a month ago, the 4th of September, the DRC declared the EVD outbreak in Kasai in the Bulape Health Zone. So far, 34 people passed away with a case fatality rate of 64.2% out of 53 confirmed cases. But the good news is that the last confirmed case was detected 24 days ago. And now we've discharged the last patient that was admitted, and the official countdown of 41 days to declare the end of the outbreak has started, which is also a great evidence of the maturity of the leadership of DSC in responding to that outbreak, on leading it with the support of the different partners, WHO, Africa CDC, MSF, ALIMA, quite a number of them were all working behind the National Public Health Institute that was really leading. So it's a change in the paradigm where we have those institutions that are getting mature and stronger, and that can really lead and coordinate the response to outbreak in their country. Next slide. The Rift Valley fever in Mauritania is decreasing. We can see that we have 6 new confirmed cases as compared to 17 last week. We also see that the number of cases are still being treated in the hospital facility with some great support in terms of infrastructure, in terms of PPE, in terms of supply, but also in terms of sensitization, because we know that it is critical to ensure that the healthcare workers and the community is well sensitized, especially in those hotspots where we have most of the cases on the side of Traza, Bracknell, and mainly Asaba. So far we have 14 deaths out of the 42 confirmed cases. Next slide. In Senegal as well, the number of deaths are decreasing from 9 last week to 2 this week, but the number of confirmed cases has increased from 81 last week to 106 this week, going toward a total of 277 confirmed cases and 22 deaths, with a case fatality rate of 7.9%. And what is also important, and that's critical to highlight, is the number of cases in the animal. Though there's 22, which is quite stable, we also record that high number of abortions that has been reported, and that has a significant impact for the pastors. You imagine that that is their living, and having those animals being either not, they don't die, but all the abortion will mean that they are not able to produce as they plan. So, however, the vaccination has been happening. More than 11,000 animals has been vaccinated. So the search team has been deployed in Luga and Matam, which are the site where we have the highest number of cases, and also the installation of the mobile laboratory with the support of Institut Pasteur Dakar in the Matam Region Hospital to ensure that the diagnostics and the management is done in a very limited amount of time. Next slide. Now, on the side of mpox, we can see that the number of suspected cases is still going down, which is great. The number of confirmed cases is a bit stable from 331 last week, 346 this week. We can also appreciate that this week we had Namibia that has confirmed its first mpox case, and then we were engaging the Minister of Health with the collaborators to have that conversation. As you remember, we have learned that out of the 5 key successful driver of the response, the leadership at the minister level in the early stage is critical to ensure that there is a proper understanding, which is the case. The Minister of Health went herself in the field to see the patient that has been exposed, and we come back to that a bit later. Next slide. So now looking at the evolution of the number of cases in country, you can see that Senegal has an increase of 200%, but just moving from 1 case to 4, which is also an indicator that there is a human-to-human transmission within Senegal, and the contact tracing is important, as we'll see later. The countries that are really concerning at this stage are really the Kenya, the Malawi, the Ghana, and especially the Liberia. Our team went there 2 weeks ago during the intra-action review, and then we'll see how the country is starting to make the change based on the feedback and that important exercise that happened. Next slide. So coming back to Namibia that we've mentioned, on the 18th of October, the Minister of Health declared an outbreak of mpox in Namibia. That is really the first time. So initially there was 1 suspected case, 1 confirmed case, which is a 20-year-old mother of an 8-month-old baby living with her partners, or 30 years old, who is actually a Tanzanian. So there is an history of travel to Tanzania, which again emphasized the fact that disease don't know borders. Now, it happened that the baby is also showing some sign of fracture, and then the result will tell us 2 things. 1, whether the baby is confirmed, and 2, what is the sequence of this case. Is it the clade 1B? Is it the clade 2B? This information is also critically important to ensure that the adequate measures are implemented. But as we've learned, as we know, the isolation of the first case, the sensitization, the community engagement are critical in those first days where the number of patients is still low. Next slide. In Senegal, we now have 7 confirmed cases, which is showing that the transmission is moving around. But the good news in Senegal is that the surveillance is pretty good. You can see that the testing coverage, the testing rate, the test is around 100%. Now, they have 4 active cases. 1 has been discharged. The follow-up is ongoing, and the contact listing, they have been listing 72 contacts for 1 case, which is quite good. Next slide. In Liberia, I mentioned that this is one of the country of concern that we have currently. As you can see, also the different indicators are showing an increase. The number of cases moved from 35 to 76 just in 1 week. And this is quite challenging because the number of cases have increased, but the test positivity rate is around 88%, which means that those cases that are increased, we see them at the level of the hospital, not in the community. And that was one of the key recommendations of our team to ensure that we implement an active search in the community, household by household, with the community healthcare workers. That is the key on managing the outbreak, as has been done in Sierra Leone. And the good thing is that during that exercise, we had some colleagues from Sierra Leone that came to support the colleague for Liberia. So we believe that we will use the similar approach of community-based surveillance, especially in those hotspots, Bush Road, Commonwealth, and Central Monrovia, that account for 70% of the case. They have been receiving 20,000 of vaccine doses that have been deployed, and so far 7,841 people have been vaccinated. We know that vaccination is not a silver bullet, so we really need to have that integrated approach where we have the surveillance working together with the community engagement, working together with the vaccination. That's how we believe that we'll be able to get out of this outbreak in Liberia, as we did well in other countries, especially in the neighboring country, which is Sierra Leone. Next slide. In Kenya as well, we continue to see some slight increase from 35 cases last week to 51 this week in terms of confirmed cases. So to total, we have 710 confirmed cases and 10 deaths with a case fatality ratio of 1.4%. The test positivity rate has decreased to 64%, but we are still far. We expect to have 30%, which means that most of the cases are really found in the community. Now, Mombasa, Busia, and Nairobi together account for 63%. Mombasa, we knew, Busia, we knew, that's where the vaccination started, but Nairobi, for the last 4 weeks, has really been consistently increasing. And we know what's happened when you have mpox in the capital city. So the vaccination effort has used all the 10,000 doses that has been received. So now there's a new allocation of 20,000 that is on the way that will definitely support the Kenya to implement the vaccination. However, you can see that the percentage of contact tested is quite low, 2.4%, which still means that when we will have those new doses, we should increase the surveillance, the active surveillance on getting the right contact. The challenge with this disease and the clade 1B and 2B is the sexual transmission. So for some population, it's difficult to disclose their partners and therefore to have the real close contact that we really need for the vaccination and all the different efforts. Next slide. Going to the vaccination, we are moving. So we have Malawi that has rolled out the vaccination on the 13th of October, making 13 countries successfully roll out the vaccination. We will see also that we are getting closer to the 5 million doses that has been delivered to 16 countries, which means we still have 3 countries that are preparing themselves to push for the vaccination. We can say that more than 1.21 million persons have been vaccinated with at least 1 dose of vaccine. Next slide. Now, as you recall, the DSC has received 3 million doses of LC16 vaccine, which is a bilateral donation from the government and of Japan. So those particular vaccine has been implemented recently, mainly in Sankuru and Kinshasa province, and 678,000 of people so far has been vaccinated. So as we do speak now, we do have some doses of vaccine that are available, though they are quite small, around 68,000 doses that has been bought. But the challenge, as we keep on mentioning and highlighting, is really the fund that is necessary to move the vaccine from where they are stored to the participant and the population where they are needed. Next slide. Moving from mpox to cholera, and you keep on appreciating how the increase of cholera is happening. And one of the simple indicators is when you compare 2022, 3 years ago, to 2025, and the year has not even ended. And you can see that we are already almost triple the number of cases and triple the number of deaths, which is showing how cholera has been increasing over and over and over the years. Now we are entering in the rainy season in some countries, which is also a big concern, because that's also when you have the flooding, that's also when you have the highest exposure, the highest likelihood to have those spread of cholera in different countries. Next slide. Now, when we look at the country evolution, we have Angola, and Angola is a big challenge as we come later. You can see an increase of 700%, moving from 396 in the week 30 to 35 to 3,000 in the week of 36-41. You also have Burundi that has seen a significant number. The number have tripled, while we see that the Congo Republic has decreased, but also seen some important decrease in other countries, including Ethiopia, Sudan, and South Sudan. Next slide. Now, in Burundi, you can see the cases are still increasing, though a bit less than the week before. We have seen 244 cases as compared to 212 last week. Good enough, we have not reported any death last week, so the total death so far is 6 out of 1,816 cases, with a case fatality of 0.4. So the hotspot there are Cibitoke province, alongside the Rusizi River, in the corridor, in the border of DRC. So the driver here is really the cross-border movement and the poor wash along the Rusizi Lakeshore River and the community. And this highlights two things. One, the impact of the humanitarian crisis, and two, the cross-border collaboration and coordination. Because the refugees are coming from the side of DRC where they don't have access to proper water, they are exposed to cholera, and also they are exposed to the humanitarian crisis. So though the crisis itself is not happening in Burundi, now they are affected. Just to highlight, if needed, that there is no health without peace. Next slide. In Angola, as we were mentioning, we were quite happy a few months ago when we were seeing that significant decrease in the number of cases. Now, we have this new wave, and the case continue to increase. You can see that we've moved from 828 cases last week to 968 this week. And also the number of deaths continue to reach a total of 842 deaths out of the 31,143 suspected cases. So we have a case fatality of 2.8%, which is really high. Remember that the threshold is 1% in the humanitarian crisis. So now we are 2.8%. This is 3 times the threshold that is considered kind of acceptable. So now the hotspots are really persistent. The Ula, Uge, Kunene, Lunda Norte, and notably Kapenda, Kamulemba in Lunda. So the OCV coverage, the vaccine coverage, cumulative OCV coverage exceeds 3.57 million people. But you can see that we definitely need more vaccine to address the population in those different districts that are currently affected. 2 reasons. The first one is that some of them have not been vaccinated in the first wave. And 2, when we are in an outbreak, and if the vaccine coverage is not 100%, 1, we miss some people who are remain exposed, and 2, the fact that in the emergency we use 1 dose instead of 2 also limit the protection of the vaccine that is being used. So it's also emphasized that the medical approach of responding to the outbreak, yes, it can stop an outbreak for some time, but you can see it come back, which means that it's the other side that is missing in the puzzle. It's really the infrastructure, the access to clean water. And because those populations don't have access to those clean water, then there's always an opportunity for the cholera to keep moving around. Next slide. Now in Chad, gladly, we are seeing a decrease in the number of cases, moving from 161 to 70 this week. The decrease on the number of deaths from 6 to 3. But as you can see, with 152 deaths out of 2008 and 20 cases, we can see a very high case fatality ratio, 6.2%. And remember that cholera, there is an outbreak where there is one case. And the fact that the outbreak started 9 kilometers, beyond 9 kilometers of the capital city of N'Djamena. Now, some of the recent cases appear less than 300 kilometers closer to N'Djamena. So which means that it's keep on coming closer and closer to the capital city. That's a big challenge. On the other hand, we are moving to the time where the increased number of rain will continue. Therefore, one, the access to the site will be more and more difficult, and the access to clean water also will be more and more difficult. So those are the biggest challenge, the high case fatality rate, the community death, the access to clean water. So as much as we want to address the outbreaks on the medical side with the great work that the Ministry of Health is doing with different partners. WHO who has managed to deploy 6 tons of medical countermeasure to respond. The other partners, MSF and others who are supporting, this is really important and significant. But if we don't solve the issue of access to clean water, then there is always an opportunity for cholera to keep on spreading, especially now where we can see some cases that are getting closer and closer to the capital city of N'Djamena. Next slide. So in summary, we are in a countdown for the Ebola outbreak. Gladly so, the new confirmed case in the last 24 days, sorry. And then we are on the countdown to declare the outbreak over. The dose of vaccine, 50,000 doses has been deployed, 36,000 people has been vaccinated. And now we are also taking advantage of this outbreak to talk more about the preventive vaccination. We have 500,000 doses of vaccine that are available through the ICG mechanism, which means that the region, the country that are at risk of Ebola can vaccinate the frontline workers, the primary workers. You remember in that Bulape, we missed 4 health workers in the early stage. So if those health workers has been vaccinated, we will have prevented that. So we take advantage, as we always do, take advantage of a crisis, an opportunity to strengthen the health system. And as the regional director of WH Afro was highlighting yesterday during the opening ceremony, is for this Ebola, 40% of the fund for response are really dedicated to build and strengthen the health system. So that if and when it will happen again, because in Bulape, you always have the contact with the environment and most likely the reservoir. When it happens, at least we have 2 things. One, the population and the health worker will be protected, but also they will have a better hospital, the better laboratory, able to detect those outbreaks. On the side of the Rift Valley, it's continuing to spread across Senegal and Mauritania, underscoring the urgent need to really push as much as possible the cross-border coordination and, of course, the One Health approach, because, yes, it's affected the human, but it's also coming from the connection between the human and the animal, in this case, the livestock. For mpox, the transmission easing across the continent with weekly confirmed cases going down to 79% from 2025 peak. We have still Kenya, we mentioned Liberia, Ghana that remain major concern, and we have Namibia that has just declared the first new case. And we really push, as we mentioned, to support the leadership, the strong leadership of our Ministry of Health to really control the outbreak at the source. On the side of cholera, we've seen the rapid escalation in Burundi with a decrease in Chad after that big escalation. And we see that in Angola, we have that second wave. That reminds us that the medical approach to stop and control the outbreak can work for some time. But if we want to limit in a sustainable way cholera, we need that multi-sectorial approach. We need, as instructed by our head of state and as re-emphasized yesterday by the Director General of Africa CDC, but also the RD of WHO, the IMST is really the platform where we need to sit all together and to ensure that we use in a very efficient way all the resources, though they are limited, those who are available, to ensure that we can control this outbreak of cholera in the different countries and move toward cholera elimination by 2030. So I will stop there and I will be happy to answer some of the questions of our journalists. Over to you, Dr. Margaret.
Thank you very much, Prof. Let's take the first two questions. We have one here. The question is, has Africa CDC considered creating a purely WASH or IPC coordination team, working with key WASH sector players from the continent to build capacity in the cholera-stricken countries? That's the first question. And then the second one says, if nothing very concrete is undertaken, statistics show that Africa will suffer the most from health emergencies, especially those related to the growing antimicrobial resistance. How is Africa CDC preparing to fight this? Back to you, Prof.
Okay, thank you. I will answer the first question on the WASH, and Dr. Mercy will be happy to answer the one on the antimicrobial resistance surveillance. So definitely, as Africa CDC, we have some experts in WASH. They are part of the IMST. They have been supporting many countries in responding to this cholera. But now the beauty of the IMST is to have all those partners. Amongst the partners, we have UNICEF, for example, which has the strong experience, expertise, and dedication on WASH. So the idea of the platform, and that's why the head of state has recommended it, is to ensure that we leverage on the great experience and expertise and the means that the different partners have to ensure that we provide the adequate response. So Africa CDC will support, but we have UNICEF, we'll have WFP, we'll have WHO, who will also leverage on the expertise in WASH. One, to respond, but more importantly, as you mentioned, to strengthen the capacity in countries so that as it happened again and again, we have people who are more and more experienced and ready to support. But once again, WASH is one thing, but the most critical thing is to make sure that there is availability to and access to clean water. So now I will hand over to Dr. Mercy.
Thank you, Prof, for those remarks, and thanks so much, colleagues, for the questions. Those are really very important questions. As we know, AMR, as we speak, is considered one of the pandemics that needs to be looked into critically for the continent. And as we all also are aware that AMR is also emerging from some of the emerging and re-emerging diseases that we are also battling with on the continent. As Africa CDC, there are a number of actions that we are putting in place because we've done some of this analysis and assessments across the continent to understand where the gaps exist. And some of these assessments include the map. We are also supporting countries also in assessing some of the issues that we have seen from the GLASS. The GLASS is one of the assessment that was done globally to look at the capacity of AMR across the globe. And from some of these surveys, including the map, the GLASS, and so many of those, we've seen a number of critical gaps that have been identified, ranging from policy gaps in terms of the implementation of some of these AMR policies and guidelines, ensuring adherence to some of the pharmacies in terms of adhering to not over-the-counter prescriptions, because we're still seeing those, and these are all policy issues that needs to be looked into. And we also have seen that we had very little capacity in terms of countries really having systems for monitoring antimicrobial consumptions. And these are also still part of the policy issues. And we've also seen that we had very few countries that had national guidelines for antibiotics use implemented in at least some of the facilities, as well as looking at countries that have adopted the AMR classification for antibiotics in their national essential medicine list. So all of these are different gaps. Of course, will require different approaches. Of course, we can't also avoid talking about the One Health bit, which is looking at the laws, the legislations in place for antibiotic use in aquatic animals, antibiotic use in animal feeds, antibiotic use as growth promoters in several countries, especially for the poultry. So these are all very important gaps and important issues that would definitely need targeted interventions for different countries and different approaches as well. So one of the things that we have done is, as the African Union will come up with an IMR framework, we've also come up with policy regulations for countries to look at adopting. We've also come with a high-level political commitment at level of the president, because we believe that most of these issues really need high-level political buy-in, and some of the state laws that really help to regulate antibiotic use as well as the misuse of antibiotics. In a nutshell, what we are doing now is looking at all of these different resources and different available resources and trying to target them based on the country needs. Because some countries would have the regulations, but again, the implementation could be an issue. Some could have in the animal sector, most in the human sector, but the animal sector is quite weak. And that's why we are really using the One Health approach, but again, targeting it to specific country needs based on the assessment that have been conducted. And we are hoping that, again, with collaboration from the different sectors, because we realize there's one key thing that is missing the AMRO fight. The One Health approach really needs to be put at the forefront. And as Africa CDC, we've developed a One Health framework that's also helping us to support countries in implementing the same, to ensure that they have very, very robust technical working groups, the One Health, the multi-sectorial coordination mechanisms, of course, being championed at the highest level of leadership to ensure that all of these policies are really trickled down across sectors and not only being supported by the human. So I'll end here, and I will let Dr. Margaret take on the next.
Thank you very much, Dr. Mercy. We cross over to the floor. We have Janice from Bloomberg. Janice, you have the floor.
Hi, thanks very much. I just want to ask, in light of the conference this week, we've spoken before on this call about looking for innovative financing, and we've talked about taxes and potentially some taxes, gambling, even certain airline type taxes. Where are we at with that in terms of the Africa CDC speaking to countries and getting any response? And if you have been getting a response, is South Africa one of the countries leading the way in using that kind of funding towards healthcare?
Thank you very much, Janice. Let's take the next one before we get the response. We have Michael from Michael Garissa. You have the floor.
Thank you, Director. So last night, the World Health Organization indicated that I think the region was this close to announcing they are still Ebola free. So I just want to find out what was Africa City's role in the Ebola response that was reported a few weeks ago, and maybe can you just comment on that? Is this something that is going to happen? And which time frame can we expect DRC to be declared Ebola free? Thank you.
Thank you, Michael. Back to you, Prof.
Thank you so much for the two questions. Though at some point I was having some challenge to hear well, Michael, but I hope that in the response we make sure that we get the best of it. So for the first question from Janice, very, very, very good question, is we are talking about innovative financing. We are talking about domestic financing, and we are also talking about this blended financing. Those are the three key pillars from the Africa CDC pushing. So now there are countries that are definitely responding very well. We have the case of DRC. This is one of the countries that has decided to pass it in the law. It's a process, definitely, to have 2% of all the importation of goods that will be now shifted in health. So that is a very good example. We have two or three countries that are also using a same model, but maybe changing from importation, maybe move to tobacco or other goods. And remember that I mentioned that the reason why we are here in Durban is also because the G20 is happening. So it's an opportunity, a real opportunity to have all those conversation to come out with a strong recommendation, strong evidence that the Minister of Health will now push to the president, to the G20 president. So now it will not be 1, 2, or 3 countries that will use that innovative funding, but a large majority. And also, we have in mind that 20 years ago, the Declaration of Abuja was signed by most of our African countries to invest 50% of the GDP in health. So now, if they cannot take part of the budget, at least we are proposing, we will recommend in how they can use that, using those innovative funds with the taxes, but also others. There are other models, the insurance and many other models that will be discussed during this conference, and will support the G20. On the side of Michael, on the side on Ebola, we are all happy to highlight that the countdown has started. Africa CDC has been in the field together with the different partners, WHO, MSF, Alima, and so on. We were actually supporting what we have really expertise from MPOX, which is the digitalization of the surveillance. We supported the country with ensuring that the data, the use of the DHIS2 tracker that can help to have the data in a real time. This is one of the key support. But of course, Africa CDC is supporting on the coordination. But the question is not exactly what Africa CDC has done as compared to others. The question is how we all coordinate, because this is a change on the way we want those outbreaks to be managed. And that was really the voice from the regional director of WHO yesterday, as well as Dr. Kaseya from Africa CDC.
Thank you, Prof. Let's take the next 2 questions. We have one here from, this is Patrick Kahondo, a science journalist from the DRC. The question is, the DRC is now moving towards the end of Ebola. How do you explain the rapid control of the situation, and what was the level of involvement of Africa CDC? I think some of that you've answered previously. The other question is from Rachel Abuja from Nigeria News Agency. The question is, how is Africa CDC ensuring that Mpox vaccines reach the most vulnerable populations in countries like Liberia and Kenya, where community transmission remains high despite ongoing vaccination campaigns? And then a question here that given that the 700% surge in cholera cases in Angola and the link to poor water access, what concrete steps are being taken to integrate water sanitation and hygiene wash interventions into outbreak response efforts across affected border regions? Back to you, Prof.
Thank you so much. I think I will go back to the question of Patrick in DRC as Ebola is concerned, because in DRC, there is a new paradigm on the way they respond to outbreaks in DRC, but also across the continent. The pillar of Africa CDC and now even WHO Afro in public health are the National Public Health Institute. Before, when you had an outbreak, Ebola or others, you will have those ad hoc committee that will be created that will respond to the outbreak. And when the outbreak is over, they are also dissolved. Now we have those structure, the NPHI, and the one of DSC has really shown a great leadership. And that also explains why it has been controlled in a very early stage. Because as soon as the alert was raised, they had the different pillar of the incident management system which is on the side of the laboratory, the INRB, which has a great experience. They managed in less than 48 hours to produce the sequence of these strains of Ebola. You also have in the other side the API, which is also one of the pillar of the incident management system. And those one were able to vaccinate more than 30,000 people within a very short amount of time. So when you have on one side a quick detection, a quick surveillance, you have the vaccination, then you manage to control with the right leadership within one district. So that is important to highlight. And that's why we were having that pre-meeting yesterday with the National Public Health Institute across the continent. 25 are fully functioning, and those have the institutional memory to keep on improving as the outbreak, as the epidemic are coming. I think that's something critical to highlight. Now, in Nigeria, what is being done to ensure that the vaccine reach the most vulnerable population? You know, the most vulnerable, it depends. The most vulnerable are the people living with HIV in many places. So that means that there is an integration with the HIV program to ensure that the people living with HIV are prioritized in the vaccination campaign to ensure that those are the key population, they will have access to vaccine because they are the most at risk of dying of mpox. Now you move to those who are the most at risk of transmitting the disease. You have depending on the country, you have the truck driver, you have the sex workers, you have some population that has been well identified. So what is being done is when the micro planning is organized, those are the key population that are targeted. And the way they are targeted is by engaging the community, the association, and to ensure that they are well considered, they are prepared and willing to receive the vaccine, and therefore the vaccination can happen. The challenge that is happening in many countries are the funding to make that available to ensure that it reaches the last mile. Gavi, the Global Alliance for Vaccine Initiative, was the main support, but now most of the country, because of those funds are limited, are finding how they can domestically fund the resources to achieve that. So in Angola, the question of WASH is what we've mentioned earlier, is that the WASH that is being used to control the outbreak is there. That's why we've managed to see the decrease after the first phase. But now what is needed is going beyond the actor of simply WASH. We go to talk with the Ministry of Finance, to the Ministry of Infrastructure and Planification, so that long-term investment are being made. As we want to recall, this is not money that we spend just to respond to an outbreak. It's not charity. It's really an investment that we are putting. You see that the number of cases of cholera has tripled in 3 years. The number of deaths are also tripled. If we consider the investment that we should have done in those countries, most likely we could have prevented that. So that is a lesson learned, and that is why the multi-sectoral approach is critical.
Thank you, Prof. Let's take the next two questions here. We have one that says, given that many African countries still depend on external funding to respond to disease outbreaks, what practical steps is Africa CDC taking to help the continent achieve real health independence without compromising the quality of healthcare? And then the second one is on the CPHIA conference. So what are the expected key outcomes from the conference that can be taken into the upcoming G20 meetings? Back to you, Prof.
Yes, thank you. So it is true that our country has been dependent from that aid, but we've seen the ODA, some of them were decreasing with time, and those others was really brutal. And when it happened, the countries has to adjust in many ways, adjusting on finding other partners, because still we need to have that leadership as African, but also we must count on the global solidarity. Why? Because we are interconnected. If something happened in Cameroon, in DRC or other countries, as we've seen in most of the disease, it may travel and happen elsewhere. So one thing is to ensure that we have partners engaged in this global responsibility. Now, the other thing is supporting country to find those domestic funds. And because it has not been happening, before, Africa CDC has recruited 10 financial officers who will go in those countries to support them on writing grants, finding the most efficient way in the environment, because this has to be contextualized. The way we manage to have domestic funding in DRC will definitely not be the same in Senegal, in Cote d'Ivoire, or in Niger. So having those 10 pilot countries will also help us to learn as we go on how the different countries catch up on the agenda of the domestic financing. So on the side of CPHIA, if I tell you now what are the outcome and recommendation, then we will not need to have all those scientists coming. So the discussion are going on. There are really big debate on the primary health care, on the response to outbreak within the IMST, or also on the issue of NCDs, how do we address them, issue of research priorities. So there are quite a number of conversations happening, and really it's on Saturday that we'll be seeing the end, that we really know now what are the outcomes. And as promised, we'll have our Director General, Dr. John Kaseya, next week himself, who will be happy to provide you the outcome of this CPHIA.
Thank you, Prof. Let's take the last two questions. Here we have one that says, can you give us an update on the security situation in Eastern DRC to the extent that it affects the response to Mpox and other outbreaks? Does Africa CDC have access to the population in Eastern DRC? And then the last one here says, this is a question on the Lusaka agenda. And the question is, could you tell us what progress, if any, has been achieved in getting African countries to contribute at least 15% of their national budgets to health? At least count only 3 countries that have met this threshold. Back to you, Prof.
Thank you. So the situation in Eastern DRC is still a preoccupation, a big preoccupation, especially for Africa CDC. You know, Africa CDC, we are from the member states. So until and unless the government of DRC will have full access to that area, it will be challenging for Africa CDC to implement the activity. However, as the IMST, we have partners, we have MSF, we have others partners who in the ground can more easily have access to those to the patient. And also, as we extend to cholera, which is present in that zone, we are also bringing on board the military humanitarian, the APORA, so that they can also have access, whereas because of our training, because of our expertise, we might not have easy access to those zones. But through the IMSC and those partners, we should be able to move forward. But this will not solve the issue. The issue is peace. So it's really at the highest political level that we should keep on pushing and ensuring that the peace is brought back, so that the humanitarian actor that we coordinate can have access to the population and solve not only cholera, Mpox, but also measles. We have many of those outbreaks happening there. So now in the time of Lusaka agenda, which want to ensure that countries really have ownership of their health, and the Abuja Declaration, which is supporting country to invest 15% of their GDP into health, those are 2 big questions that are being discussed as we do speak now. There is one session on health financing, on how we've been moving. Unfortunately, I'm not there, so next week definitely we'll be having all those the answer to all those questions, and then to give you a proper understanding of the state of the continent, but also how we moved from there to recommend for the G20, which will happen here in South Africa.
Yes, just one follow-up question from Janice from Bloomberg. Janice, you have the floor.
Thank you. Just in line with discussions that are being had, I know for at least 4 years we've been talking about getting vaccines and other pharmaceuticals made on the continent. And I know that it's a fairly long-term strategy. These things don't happen overnight. But could you give us any updates on any practical steps that are being taken to ensure that that is actually happening? Certainly in South Africa, you know, a lot is still being procured from India and Germany. And we do have some manufacturing capabilities in the country. But yeah, if you've got any update on commitments to ensuring that more is made on the continent and bought by the various governments, even if it's marginally more expensive initially.
Yes, thank you so much, Janice, and thank you for your perseverance. I was seeing your hands, and I'm happy that you had the opportunity to ask your question. No, it's a big challenge. We have to be honest. The local manufacturing agenda is not a simple one. When we talk about the next independence of the continent, it means that we'll have to fight for it. So what has happened concretely? I will speak about Mpox. We've been highlighting the discussion that we're ongoing with Bavarian Nordic, which is the main supplier of vaccine currently, and a company in South Africa. So the capacity to actually do the transfer is there. The willingness is also there. So what is missing in between is to ensure that we have the adequate demand so that the 3 to 4 million doses that are needed for the tech transfer to happen actually happen. Now, the demand itself is there. You remember that we had the smallpox before, and then we vaccinated. We had those vaccinated campaigns that end in the 1980s, and that's when smallpox being out, Mpox start to increase. So now we need to find the right strategy to ensure that we increase the herd immunity in Mpox endemic countries. We have DRC, we have CAR, we have Nigeria, we have some of those countries. And that represents millions of people. So the actual demand in terms of needs is there so that we can really stop the Mpox because we don't know which mutation can happen. Now, the challenge is how do we pay for those doses? And this is the conversation that is also being discussed, how the domestic financing can address that. How can we also find maybe new vaccine? We are talking about the mRNA. There are other candidates so that we can reach a point where we can have the demand, which is there. We also have the technology that is available in the continent, in South Africa, in Senegal, in Egypt, in other countries. We bring all of them together. So this is the push for Africa CDC, and then we'll make sure that it happens. Over to you, Director Margaret.
Thank you very much. Let me just check. There's, I think, one more question here. This question is about the cholera outbreak that's ongoing. So the question is, the hotspot showed that year by year from 2022 until now, more countries keep getting cholera outbreaks. What steps is Africa CDC taking for the spread to stop, and what measures are being taken to curb this present outbreak in severely affected countries? But back to you, Prof.
Yes, thank you. I will let Dr. Mercy answer the question, and if needed, I can complement. Over to you, Dr. Mercy.
Thank you, Prof. Just to take on this question, it's really true that the spread of cholera has been on the rise, and this is as a result of several factors. We know that climate change is also contributing massively to the spread of cholera on the continent. We also know that the socio-political crisis is also a contributing factor. So it's beyond just a public health problem, but a multifaceted problem that needs to be looked at it from a multi-sectorial point of view. And at Africa CDC, that is why we had been able to convene or use the convening power of the AU to bring together our heads of state and government, and as well as ministers of health, environment, water, hygiene as well, and environment, just so that we can look at this situation from a holistic approach, looking at it from a holistic approach. And we came up with a number of commitments and a call for action that also the member states are beginning to implement. And one of these recommendations that stemmed out from this meeting that was convened, that brought together the heads of state, was that there was a need for the integration of cholera into the incident management support team at the continental level. That also shows that the heads of state are really advocating as well and really advising the response to take a more coordinated approach than before. So initially, you see Africa CDC supporting some countries, WHO be supporting other countries and all that. But looking at the situation where we have the decline in ODA, that's the official experimental assistance, there is really need for more institutions to come together and really have a robust plan that will guide the response. And this team have been able to come up with a continental cholera response plan. And so far, this response plan is guiding the support for the different areas that have been identified, as well as the priority countries that are targeted. But most especially, and most importantly to mention, for the very first time now, we've seen peace and security arm of the AU, the UN, also being part of this plan, whereby we are all having indicators that needs to be looked into and monitored as we progress in the response. This has not been the case in the past. And this is really showing us that we are really taking the right steps in the right direction. The second thing that we're also looking at is strengthening the climate change perspective, and looking at integrating climate data into also informing how we prepare ahead of possible outbreaks. Now we are looking at climate data to help in early warning, so that for areas that are very vulnerable, that we know maybe that have been mapped and definitely have poor watch infrastructure. And if there is an early warning sign from the climate data that we are seeing, we are able to support those areas intentionally to put in preparedness measures, just so that we are able to prevent spillover from the environment to the human. And thirdly, one of the other areas that we're also supporting the countries to do is supporting with the wash infrastructure. And beyond that, in the primary healthcare, again, is another issue that is also being looked into. And these are the bedrocks of a very robust public health system. If we don't have the wash right, we don't have access to primary healthcare, right, definitely will just keep struggling and being very just reactive to the response. So we have really identified the foundational elements that needs to be put in place and getting them right in terms of more or less the preventive bit of it. And lastly, the vaccine mobilization across the continent. So now we are going ahead of the curve to now look at stockpiling to more or less reactive. And these are some of the conversations that have been they are taking place, and through that, we are sure that we are able to also mobilize vaccines for those very critical areas that have been mapped for the response. I don't know if Prof has something to add.
No, I think I have nothing to add. I will hand over to Director Margaret. Thank you, Mercy.
Thank you, Prof. and Dr. Mercy. And with that, we've come to the end of the briefing this week. I'll hand over the floor back to you, Prof, for your closing remarks.
Thank you so much, Margaret, and thank you to all the journalists. You received an invitation 2 days ago, just confirming that we'll be talking to you, and then you are there, as you've been with us all through more than 56 weeks that we've been having this brief. So we don't take it for granted. We really appreciate your commitment, your dedication. Most of you are online. We also had some journalists here at CPHIA. Yesterday, we had that great engagement with some of your colleagues. We really appreciate that moment where we have that transparency, we have that accountability, and you really help us and push us to move toward the excellence on how we respond to public health in the continent. So we are happy to be here in Durban for the CPHIA to celebrate. I have to mention the African leadership, having all the Africa CDC, the Director General, Afro, Adi, and so on, coming together really to ensure that we have all our thousands of African scientists and more than 20 plus around the globe actually thinking of how we can find homegrown and African solution. And those solutions will feed the G20. We have some strong commitment and engagement to respond to some of the questions that you've asked. So we believe that next week we'll have a bit more answer, and that those answers will be provided to you by our Director General, His Excellency Dr. John Kaseya. With that, I thank you all, and I wish you a good day, a good afternoon, or good evening. Thank you.